Hello, I'm Ron Hopkins, and I'm probably one of the older guys in this room, along with a few other faces I see. And, you know, one of the advantages we have is being the old guys here, we've made all the mistakes. And that's really where the learning curve is once you make those mistakes. So what I'm going to try to do is give you the practical things and avoid the mistakes. So, transradial fitting principles. What is there to say about transradials? I mean, we've all fit transradials and we think we've done them pretty well. But what happens when we get into those complicated cases? Those cases where you've got a kid that doesn't fall within the norms? What happens when you get into the multi-level individual, the bilateral, the quadrilateral? All of those things are of magnificent concerns to us. So, in my personal opinion, it's all about outcomes. Really, isn't it? When you think about it, when we do our fittings, we should be thinking about what is the outcome of my decision? Is it the best decision I could possibly have made? Well, part of that really has to do with a couple of other questions we have to ask ourselves. Is the system intuitive? I learned that a long time ago. If the system is not intuitive to the patient, your failure rate's much higher. And does it do what is predictable for the patient? So, if I'm intuitively going to produce a motion, can I predict what the motion is going to be, and even if I can't see the hand or the terminal device? So if you work in that regard, and you're looking at strictly outcomes, is it intuitive? Is it going to be predictable? Our success rate's going to be much better. Because I can tell you, too many of us have had those patients that put the devices in the closet, and then it's worthless to everybody. It's worthless to you, it's worthless to the insurance company, it's worthless to the patient. So let's make sure that when we design these devices, we do it in a most appropriate way. Now, obviously, we've got 3 levels in transradials: short, mid, and long. But each one of these levels has a specific concern that we have to think about. Look at the kid up in the corner. That's a really short little transradial. And I'll show you how we handled that one. I'm going to do some case studies to show you how to interpret and how to handle some of these more difficult cases. The mid-range, depending upon the sex of the individual, the activity level of the individual, it makes a big difference. The longs. Long ones are probably the easiest, but the most time-consuming. Wrist disarticulations are very, very time-consuming to construct. So, our main areas of concern: range of motion. Weight of the device is certainly important for that child. Supination and pronation is important. How we handle it, whether we do it anatomically or whether we do it mechanically. Wrist flexion extension and wrist radial deviation. How many of you guys have considered the importance of radial deviation? Most of us haven't. However, if you think about it, when we feed ourselves with a dominant hand, what are the motions that we perform? We perform elbow flexion, wrist deviation, and grasping, right? Think about that. Take your hand, put it straight, and try to put something into your mouth. Just like a fork, put it into your mouth. I have to make these gross alterations in order to get it into my mouth. What gets that fork into my mouth is radial deviation. Do it, put it in radial deviation, now put it in your mouth. It comes straight in. So, for years and years and years, I've been complaining to the manufacturers that they've given us all these wrist flexion units, but no radial deviation. We have to actually allow for that in different ways, either pre-positioning the wrist or building something else. The unilateral is a generally pretty straightforward case. The range of controls One of the things I always lecture to the therapist is, and they always ask me, how do I measure whether this is going to be a good outcome patient? Well, if the patient can perform 4 gross motions, spatial motions, they're probably going to be a successful user. Those 4 motions are grasp, extended grasp, whether it be over the head, this way, right? Midline, at the mouth, and at the foot. If the patient can do each of those motions, he is probably going to be a pretty successful user. If he can't, you as a prosthetist need to find a way to make it happen. Dominance is a big issue for us because when the therapist starts to train, if the affected arm is the dominant arm, obviously the other side is now going to have to be part of the training effort. So as much as we can get out of the prostheses in its ability to range all of that global space and do and perform those actions, then the better off we're going to be. Other limiting factors. Other limiting factors are generally other anatomical factors. I'll give you an example. I had a lady that was referred to me. She was a shotgun victim. And this poor lady, she was actually working in a store, and her husband came in with a shotgun. They'd had some dispute. And so he walks in with the shotgun, and he points it at her. She raises her hand. He fires the weapon. It goes through the wrist, through the side of her neck. When they finally got her to the hospital, the pellets from the shotgun stuck in the artery, traveled to her brain. She stroked the other side. All right. Is she a unilateral or bilateral? She's a bilateral patient now. Yes, it's a very limiting factor. So I have to treat her as though she is a bilateral patient, even though she's got one sound side that is non-functional. The activity level of our patients is of huge concern because you've got all of these kids. They're on monkey bars, gymnastic equipment, all kinds of things. We're certainly going to treat them differently for sports and special interest. The vocation. Some of our patients are bank tellers. Their consideration is going to be a lot different. Funding sources, huge complaint of mine. Funding sources are so limited these days that for you and I, it is now one of the biggest determining factors of how we treat our patients. And I think it's totally unfair. However, when we consider what we're going to use in the prosthetic care, we have to consider the funding source. Support systems within the family, support systems within the community. Those support systems are huge factors. This lady that's down in the corner down here, she's quadrilateral. She lost both arms, both legs. She went in for a gastric intestinal procedure. She blood clotted through all 4 limbs, and she woke up not only with a colostomy, with also all 4 limbs subsequent to that missing. All right, as far as interface designs, I think they're fairly straightforward, but I'll go through them. We have laminated hard sockets. Most of us use a flexible interface these days. However, there are people that really want laminated hard sockets. Flexible interfaces, frame sockets as a result of these two, those are transradial anatomically contoured or just anatomically contoured sockets, ergonomic sockets, and the Toronto 3/4. If you could actually group all of those in together, they're mostly anatomical stuff. On the other side, on the unframed side, and you've seen it in your coded, they have it framed and unframed. On the unframed side, you've generally got Munsters. I haven't seen too many framed Munsters, and split sockets. But within those two, there's some really interesting cases. This is a gentleman that likes that hard socket. framed. And the importance of framed outside of just anatomical control. This is a gentleman who is a multi-level. He's missing his left arm. He's also a hip disarticulation on the other side. But he uses a walker and a platform. He needs the feedback from the elbow on that walker in order to walk. So part of my consideration when I made this design was to make sure that he had feedback on his forearm so he knew how much weight and direction he was moving. Split sockets. Very interesting part of this. How many of you guys have done split sockets? Done a few split sockets? Yeah. Show you how to do that. It's really a pretty interesting group. Anatomically contoured. Obviously, we're using the muscle groups and the skeletal section in order to gain greater control. And there are times when you can use that system, and there's times when you don't use that system. This is part of the original, help me out, Chris, that came out of Sweden, I think, originally? The Netherlands. Yeah. And it was one of those that kind of preceded all of the others as far as anatomical control, and to be able to make it lightweight and less of a heat issue. While I'm on the issue of sweating and heat, did you guys know that you can use antiperspirant on the arm and it'll shut down the perspiration? It does it very well. So those patients that you have that are complaining that it's too hot and sweaty and they get loose inside the sockets, the dry antiperspirants work extremely well. They can just buff it on, and they'll stop sweating. Works well. They can use it for long periods of time, no problems. The 3/4 was also a design that was, the Toronto 3/4 was a design that was produced just after that last picture I showed you, which allows greater comfort in the elbow and being able to have less pressures overall but get good suspension. All right, here's the first case study. This is the guy you saw first with that hard socket. This guy is 71 years old. Date of injury was 1974. He's a hardware store manager. And his dominance was right hand, and the date of the first fitting was 1975. I've been seeing this gentleman since that time. He's had myoelectrics, he's had gripers, he's had all kinds of stuff. What do you think he prefers to wear? That hard socket. So it just goes to show that, everybody is not a patient for new technologies. There are patients out there that just have a preference for the old style fittings. Anybody ever fit an old polio? Those old polios, you can't change them. Those people, you can try everything in the world, but when you finish up, you're going to have the same design that you started with. It's just a point of fact. All right, I'm going to jump over just so that you can see him. Yeah, put your arm out to the side one time and open the device. Good. Put it over your head one time and open it. Good one, open it. Good. And then put it down by the shoes. Down by the shoes. Good. That's fine. All right. Do me a favor. Take it off so I can see the length of your arm. Good. Doesn't like much to design. It's just a straight plug fit. That's what he's satisfied with. Some of these patients are like that. Case number 2. 41-year-old male. His date of injury was last year, the June of last year. He's a ship hand, and his dominance is right-handed, and the date of fitting was 2012. Let me give you a little background on this guy. Interestingly enough, he was down in the machine room, and he was down there in the dark, and they have this huge fan that cools the equipment. And there was a power failure on one of the control slots. So the captain sent him down to reset this circuit breaker. And he said when he got down there, he knew that the fan was behind him. So he turned and he made the adjustments. He reset the circuit breaker. But as he turned back around, his hand went into the fan. When I first saw him, the surgeon called me in. He said, "What can you do for this?" Essentially, he was a transcarpal at that point. He was missing half the thumb, all of the fingers. And we got into a discussion with the gentleman. He's only 41 years old. He wanted to get back to life, and he wanted to do it soon. And the doc said, "Well, you know, we can do some reconstructive stuff." And the guy was totally against it. And he said, "You know, I need to get back to life as soon as I can." And I quite agree with that decision. At any rate, when we finally discussed the situation as far as his activity level and all of the other things that he wanted to do, he had one request, and that was that he wanted to continue to lift weights. He wanted to be able to go to the gym. He wanted to be able to do all of the things he had done before. However, he wanted the latest and greatest in myoelectrics. Well, a lot of times, if you think it through, you can actually do hybrid systems so that you can incorporate your design so that it matches everything. Because the insurance company had already told me, we're going to buy one prosthesis. That's it. We'll buy one. We won't go for another. And so, you know, my encouragement to the caseworker was, let's do the design for the myoelectrics, but I can also make it a hybrid system so he can connect all of the other stuff that he wants to do to perform the stuff in gym. So this gentleman, he's quite a character. We ended up doing a Transradial just above the wrist so that I could get the equipment into the arm. One of his other criteria is that he didn't want all batteries hanging off the arm and a lot of other stuff exposed. So the surgeon had asked me, he says, "Okay, if I'm going to take this arm." So I told him, I said, "You know, I need at least 3 fingers above the wrist disarticulation area, or at the wrist, in order to get the batteries in there and the other equipment that I need to run this device." So, nice guy. We ended up fitting him with a steeper hand. Performs extremely well. Can you change the modes for me one time? Can't change the mode. All right. Can you put it out to the side and do the same thing for me? You're sitting down in the middle. Self-suspending socket. What you'll notice on the outside of the arm are the attachment points for the cable control. We use the Autobach threaded adapter in order to put a grip 3, the TRS grip 3, on that, so he can pop that thing in and out of there really quite quickly. He also has one for doing push-ups. It looks like a fist. For those of you who haven't seen the dexterity on these multi-articulating hands, he's a good example to demonstrate that. how many of you guys have fit the multi-articulating hands? I know that Pat and Chris and yeah. So there's a relatively few number in here that have fitted it, but you know, I wasn't a big believer in this in the beginning. Certainly the insurance companies are not a big believer. This guy can do those rubber bands really quite quickly. I didn't continue that film right there, but very dexterous. This was really impressive. Cute guy. He's really quite motivated. You know, as far as individuals go that have accepted their level of care, he's probably one of the best. I had another patient that was a young woman, 19 years old, that was in an automobile accident way back when the automobiles, some of those autos had gas tanks that were exploding when they were hit. And she got out of that accident, but she lost her arm. Actually, she lost her hand. And one of the bravest individuals I've ever seen. We went into the hospital room, the surgeon was there, and she's 19, and we asked her, you know, how she'd like to be treated. And she said, how long is it going to take me? I've got to go to school. I've got a life I've got to, you know, continue on with. And we said, well, you know, if you do reconstruction, it's going to be a long, long period of time. If you go prosthetics, we'll probably have you using something in 3 weeks. She said, take it off. I mean, it really stunned me. But this guy is equally as motivated in the use of prosthetics as she was. Case number 3, 49-year-old female. Complications of surgery. This is the one I told you about. That's a quadrilateral. She's a seamstress. And it's kind of sad because I don't think she'll ever go back to the job. She'd like to. She and her husband own a seamstress shop. And she, a heck of a nice lady, but and very, very motivated and doing very well at this point. She was right-hand dominant at the time. She's still right-hand dominant because that's the arm I set up for the dominance. Date of the first fitting was just March of this past year. And you'll notice in the right arm, it's configured differently. The left arm is relatively straight. The right arm has a flexion cant to it, 15 degrees, and a radial deviation cant to it, of 15 degrees. So it's sitting in a position so she can feed herself, right? So you can pre-position these wrists as long as you know what dominance they're going to have for feeding. One of the other ways that I tell the therapist whether a patient's going to be successful in their outcomes is when they start to gesture with their hand. When they start the gesture and they're talking to you with their hands, they own the arm at that point. It's a great measuring point. Good. Now right down by your waistline, do it. Again, the four global areas of control. Wrist control is controlled with pulse on the Ottobock pulse wrist. For those of you who haven't used pulse, it's actually an amplitude. If she hits a strong amplitude, the wrist rotates. If she hits a small amplitude, the hands operate. But she understands it extremely well. And what are the things that we have to consider when we see a patient like this? First, how is she going to get the arms on and off? Right? It's got to be relatively simple for her. I mean, yeah, she can probably get somebody to put the arms on for her, but that's not our goal. That's not our outcomes. We'd like to be able to have the patient put the arms on by herself, and certainly now she's going to have to put the legs on afterwards. So she puts the arms on first, and that's part of her training, and then the legs. Believe it or not, these are suction sockets. So how do we handle that? Well, the easiest way to handle the suction socket is with a straw. If you have the arm sockets there, and they're designed as suction sockets, and you're using suction electrodes, because Ottobock makes those suction electrodes that are flush, if you moisten the arm and you put a straw in the socket, you can push directly down, the air will evacuate, you can pull that straw out, and now it's strictly suction. And it works every time. Straightforward, intuitive, easy to use. You'll notice, I'm going to run this one more time. You'll notice that we use a silicone sleeve above at the elbow, and that's as a safety backup for that suction, because she can't afford to have these arms come off. Can't happen for her. Not only that, it's cosmetically appealing, and one of the things that we find we always have to consider particularly with the Asian patient, is the cosmesis. They not only want it to function well, but it's got to look good. Good. Now right down by your waistline, do it. We use the speed hands. You know, back in the 80s, I was complaining to Ottobock and to Motion Control that their hands were too slow, because all of my patients were coming to me and going, I don't understand, but I've got this headache. I get this headache all the time. It's related to the prostheses. So, you know, one day on the next case, I sat down and I really talked to this patient. I said, what is it about that hand that gives you a headache? He said, Ron, it's too slow. He said, my mind thinks twice or 3 times faster than that hand. It's got to be faster. At that point, we double voltage the arm, and Ottobock said, you just voided the warranty, and I think it was Pat that told me that, or one of his predecessors. So we put in 12 volts. It doubled the speed of the hand. But the drawback is that you have to replace the motor every 6 months. It burns the motors out. So that's when I learned to replace the motors. Did you know that you can replace an Ottobock hand motor for 40 bucks? Ottobock charges you 400? Huh? You know, some other necessity. I mean, yeah, $40 you can buy it from Micromo out of Florida. Put that thing in about 10 minutes. Takes you about 10 minutes to put it in. So every 6 months he comes in, I replace the motors in his hand. She's pretty agile. Oh, the other thing I wanted to point out about this lady is that how does she plug in her arm? You know, that's the other consideration, is how do they power the arm? These are internal batteries, and for those of you who may not recognize that, that's the Autobach integral system. It's connected to the batteries, and that's the way it's charged. And it's magnetic. And so their magnetic end of their charge unit, they just flip it over, and it'll stick right in place and charge that unit. Very, very easy for a bilateral to do. This is probably one of my oldest patients, and one that I learned the most from. It goes back to 1986. This gentleman, 76-year-old now, but his first injury was in 1986. And at that time, he was an electrician. And we fitted him the following year. But when the surgeons called me into the hospital to do the consult, I learned that this gentleman was on one of the cherry pickers, you know, the lifting cherry pickers, and he went up to take wires down. And the wires were supposed to be dead. And he said, I tested those wires. I know they were dead. So he went up. They were going to strip these wires down. They were old wires. I said, well, then how did you get electrocuted? He said there was a lightning storm 5 miles away. He said the lightning struck the line 5 miles away, came down, went through my arms. Strange accident. When I got there and I saw the gentleman, both arms were black all the way up to the elbow. I mean, cooked charcoal. And the surgeon said to me, he said, I don't think we can save the elbows on these arms at all. I said, well, you know, one of them looks like it's pretty well gone, but whatever you have to do, leave the other elbow in place. I have to have one elbow that's going to become the dominant arm. And he said, I won't make any guarantees. He said, because I'm going to have to skin graft that entire arm at the cubital fold distally. I said, I don't care what you've got to do. Give me that elbow joint. He said, well, it's not going to range. I said, I don't care. Just give me the elbow. Even if you've got partial range on that elbow, that's what I need. Leave the other one, let it go above the elbow, but leave that one for me. So he ended up with a left arm that was below the elbow, and you can see he's not fully flexed there, but he doesn't have much more flexion than what you see in that position. And the right side is what we consider now to be the assist. His dominant arm is the left side. His assistive arm is the right side. And we designated at the time we did the fitting what arm was going to perform what action. The left arm had to be the feeding arm, so it had to be able to acquire all the facial area behind his head, combing. He had hair then. And so he had to be able to comb his hair, brush his teeth, do all the things that he would normally do in life, drive his car. He does that very, very well. But the right arm needed to be the one for toiletry needs. Get behind him, hold the toilet tray paper, do all of the necessary things that you would normally need in your toiletry needs. So that's the way we designed it. We designed it with a 5XA hook on the right side and an Autobach myoelectric on the left. Okay, he's got about 45 degrees of total flexion. You'll notice that the forearm is split. You'll see that operate in just a second. But he's got a split socket, which allows him to acquire the range wherever he needs, up around his face, his head, down by his shoes, out to the side. Take your glasses off. This was the gentleman that told me it was giving him a headache. and that I needed it faster. And so the hand operates right now as fast as it did back in 1985 when I put 12 volts in. Now we handle the inputs on the electrodes very differently. You'll notice that as a split socket, we don't have a lot of room for migration of the residual within the inside of that arm, because anything that would happen inside the arm is sitting on top of scar tissue. It did graft, full thickness graft, all the way from cubital fold distal. So how do we get an input? You can't put a standard electrode on that. Now, he just demonstrated what happens when the arm is straight, but you'll see him now put the arm into radial deviation. Radial deviation is always in the direction of the thumb. Extremely agile guy. His wife came to me she came with him one day when he came in, and this was in the 80s, about 87, 88. Watch him open that hand. He knows exactly where the position of those fingers are. His wife came in, and she said, "You know, you made him too good." I said, "What do you mean I've made him too good?" Well, he's a firefighter. He is the captain of the fire force there. And she said, "We got a call the other night, and he didn't come home for a while. I was worried about him, so I went out to find out what was going on." She said, "I found him on the roof with an axe in his hand. You made him too good." I said, "Well, at least I've given the man adequate controls." Now, the way we handle those controls is that we use TENS electrodes on him. And TENS electrodes, I've used them now, probably for 15 years anyway. TENS electrodes are the electrode patches that normally a therapist would put on in order to get muscle control. I mean, what they're doing is they're putting an electrical current in. TENS electrodes will also take an electrical current out. It's nothing more than having those buttons on the preamps connected in a little different way. So on him, he's controlled no matter where he is. Behind his head, outreach, behind his back, every place he is in full control. It never migrates. Can't migrate. It's an electrode that's stuck to his skin. So we have extensors, we have flexors, we have 3 electrodes on the inside, 3 electrodes on the outside. He puts those TENS electrodes in place for 3 weeks at a time. Never takes them off for 3 weeks at a time. I'll show you the harness, the wiring harness that I use. But in order to connect it, he can do everything he wants with these arms. He can put the arms on and get them in place. Connecting the actual electrode junction is the thing he has problems with. So his caretaker or his wife or whatever has to actually plug that in. And what we use is a 5-pin mic connector. The 5-pin mic connector serves us very well because the 5th pin is always the double ground, right? So you've got a EMF source at the top, EMF source at the bottom, and you've got a ground in the center on those preamps. The 2 grounds in the center can be wired to 1 lead. So we've got 5 wires coming down off of these leads into the preamp. The preamp interprets it just like it would if it were a straight electrode. Case number 5. Another interesting case, because this was another one that the surgeon called me in on, and asked me to predict or figure out what we were going to do with this child. 4 years old. You'll notice from the x-ray here, you can see the technician's hand on the side. That's how young the child was. He was only 5 months old at that time. And you'll notice that the humerus comes off, but there's a spur coming off of it. And then distally, you can see what looks like an ulnar remnant. So the surgeon said, I'm probably going to go in and I'm going to take this spur off. I said, don't take the spur off. I said, put the spur someplace else. Place it distally on what I think is the ulnar remnant. I said, let's at least give it a chance. You know, you guys have got plenty of taking off tools, but you don't have much in the way of putting on tools. And he said, you know, I probably agree with you there. I said, well, let's give it a chance to articulate. If we can get it to articulate, we've got an elbow articulation. So he did. He took it off there. He placed it distally. And you'll notice that it even looks like it wants to articulate by the design of the distal end there. Nice little kid. Now he has an articulating elbow. He has the little nubbies on the end, just like you would on a standard congenital case. And you can see the electrode mark up on the inside. The electrode we placed on the triceps. Right? So he initially started off at 5 years old with a passive device. Worked out very well for him, but essentially it was a banana arm. Then his parents, of course, wanted to go on when he was about 2, and we fit him with a switch-controlled System 2000, which was a cookie cruncher. Well, this last time that I saw the child, and he was articulating that well, the parents said, okay, we'd like to go to myoelectrics now. Ooh, you do? How do I get an electrode on that little short stubby arm? It's never going to stay there. I mean, even if it's inside the socket, it's going to migrate as the child articulates the arm. So, what we did on this child is we put a triceps cuff on there, split the socket, put the electrode in the triceps cuff. So now when the child uses the triceps, and he wouldn't normally use that anyway because he's going to use the biceps to raise the arm, but the triceps he doesn't have to use because the arm is going to fall with its own gravitational forces. So that's what he uses. He uses the triceps for voluntary opening. It's automatic close at this point. But I'm beginning to believe that in the future, I'll be able to put an electrode in the triceps cuff for opening and in the socket for closing. The hand while you're there. Can you do that? I've also put a lift assist on the lateral side. This is the first time this child's had this. First time he's put it on. And watch his control. See, I put a little cable lift assist on the outside because he's just not strong enough to get it up at this point. But he can get it all the way up to his face. And his parents called the other day. I wanted to get some more films of it before I left, and they said he was doing great. So, but you know, I think a lot of times we need to think out of the box. We're too used to just doing these transradials in a standard way. We need to really think about what our outcomes are going to be. We need to be able to perform those 4 functions. I don't know whether, I think I'll probably have him stand there and do spatial controls. But he could do that fairly easily over his head, out to the side. He wants to carry the arm. And needless to say, his parents were very happy. I've always said that, you know, in these congenital cases, first thing you have to treat is the parent. Treat the child last, because the parent is really the key to having, you know, successful outcomes along with therapy session. If the parents are not having the child continue to wear the arm, probably won't. Okay, I'm not going to go through a lot of the control methods and socket suspension methods because I think we've already pretty much covered that. Robert covered a lot of that when he was up here. And this is nothing but a rehash of a lot of that. Everybody understands passive devices. Here's an interesting case that Jack Eulendahl did, and that's the suction socket. But you'll notice what he's done with the suction socket. He's made it relatively small so that the patient puts the socket on first and then clips it into the arm. I thought that was pretty unique. I think I've run out of time here. I wanted to show you that connector. As far as the connections go, I didn't put the motion control electrode or the controller up, and that's the one I normally use for handling the split socket control method that you see right there. And you'll see right here, this is that mic connector that I talked to you about. And that mic connector, this whole thing can be unplugged at the top, at the point of the TENS electrodes. They're just simply unplugged. He leaves them hanging, the tail's hanging. He's got them in place with a piece of moleskin. And when he puts the arm on, he brings they actually plug in that mic connector straight down. This is not working anymore. Anyway, the wires come straight down into a motion control controller there in the forearm. Hopefully I've showed you some kind of intuitive things or ways to handle the patients that are a little bit out of the box. And if you take anything away from this, it's the outcomes. You've got to have good outcomes. No prosthesis should be in a closet. Thank you much, Ron.